Manos and Manos, for inviting me again to this outstanding course. And again, congratulations for again outstanding course in Athens. I'm going to talk about the stemless reverse shoulder replacement, advantages, disadvantages, and give you some more than 16 years of results. My disclosures, I'm the designing surgeon of this implant, so I've got a conflict of interest here. Reverse shoulder replacements are gaining popularity around the world. We all know that, but that's not without problems with glenoid notching, stress shielding, and resorption of the tuberosities and proximal humerus, limited rotational movement, we just heard about it, periprosthetic fractures, revisions, which are not a simple thing to do, etc. And we see more and more of these cases, revisions with longer and longer stems and less bone stock. And I ask you, what to do next? And this is actually just the tip of the iceberg, because more and more of these implants going in, more of these disasters we're going to see. So we have to adopt a different attitude and a different point of view about these patients. We have to plan the patient or the shoulder of the patient journey through life and preserve all the options for future revisions if will be necessary. And here comes the importance of the bone preservation. So let's think about what's the ideal humeral component. It should be bone preserving, should be easy and quicker insertion, advantage if it can be done under block only or local anesthesia. It should have good initial fixation and stability, longevity, no stress shielding, and good load transfer under the prosthesis, good rotational movement for activities of daily living, and easy revisability if it will be needed. So with that in mind, many years ago, since 95, but we came with this idea of the stemless reverse shoulder, which is the Verso. It's got a triple finned stemless metaphyseal prosthesis. And we resect only a minimal amount of bone, and actually we use this bone for bone impaction into the humeral head. It's a total metaphyseal cancellous fixation without any diaphyseal stem. And as I said, with a bone impaction technique, we can use it in most of the cases. We have now more than 16 years of experience since 2005. Again, just to say it again about the bone impaction, which is important, and it's a total cancellous metaphyseal fixation. Now, just as a definition, this is a stemmed implant. This is a short stem implant because still there's a stem in the diaphysis, and this is a stemless or metaphyseal prosthesis. On the other side, you can't talk about prosthesis without talking the other side. The other side is a glenoid with a base plate, which is this conical tapered screw, and this is actually in a study in Imperial College showed that it's very excellent fixation to the bone with minimal micromotion. And another thing that we have in this implant is the lateralization of 3 millimeters of the glenosphere and this angled dialable liner that helps to prevent the impingement or give impingement-free movement under the glenoid. So this is one study of patients with 5 to 12 years follow-up. Again, you can see the movement. Again, look at the rotational movement. This is more important than elevation. And you can see the results. Overall, we had improvement of the constant score from 22.1 to 86.8 as the HSX adjusted constant score. We looked at bilateral shoulders to see if there's any problem with activities of daily living, which we couldn't find. And you can see the different results for the different diagnoses in the graph below. Radiographically, there was no lucencies around the implants. There was no notching in the majority of the cases, but in 20% of them, there was a grade 1 or 2 glenoid notching, and only in 6 cases, that's about 3.5%, we had notching grade 3. Again, we haven't seen any subsidence, loosening, stress shielding or lysis of the tuberosities in more than 16 years. Overall, the results are remaining good over the years, and you can see this is a recent study that actually is still preliminary results. We're doing it now, is patients more than 10 years follow-up, 10 to 16 years follow-up. You can see this lady here 15 years down the line, and we managed to follow 97 patients out of this series. 95 of them died. Unfortunately, these are elderly patients. They died along the line, but we know that they died satisfied and happy with their shoulder. The constant score, again, improved the age and sex-adjusted constant score to over 100%. The SSV was 8.73. So there are other series. I mean, there's a good series that Andreas Leonidou actually performed in Kent, and there's a series from Italy, Micheloni, and another series from Kent that shows similar results. Stress shielding is a major problem with stemmed implants, and this is since Barbara Mellis and Jill Walsh started to talk about it. And actually, surprisingly, even with a short stem, it actually appears quite early after the implantation. And this is a worry, because what do you do if the proximal bone disappears? We haven't seen it, and again, the only difference is maybe because it's only cancellous fixation with good stress distribution under the implant. And this fits what the study of George Atwell that showed that stemless, more than short stem, more than long stem, mimic the intact bone stresses and provide adequate component fixation. So what do you do in young patients? I mean, we have more and more young patients. This young lady at the age of 22 had a total Copeland resurfacing. She was the youngest patient that Steve Copeland did for juvenile rheumatoid arthritis. This is 23 years later. She lost the rotator cuff, as you can see, and she's painful again after 23 years with a Copeland. So I revised her to the Verso, and this is 6 years later. She's 51 years old, still young. It's got excellent range of movement, best that she ever had, and all the bolt stock is there. And this is actually this year, 12 years down the line, again, the same as she was 6 years ago, and she's delighted. This is, I believe, the youngest patient that was done ever. It was done by my colleague, Dr. Martin Abogast in Germany. He's working in a center for rheumatism in Obermagau. He gets referrals, all the disasters from all over Germany. She's 15 years old with juvenile rheumatoid arthritis, very restricted, very painful. This is 3 months after she had the Verso, and obviously she returned to do all the sports and everything, including this kite surfing. So I don't know if this will remain and stay like that for the rest of her life, for the next 60, 70 years, but all the bone stock is there, and then if something needs to be done in the future, you can do that. Again, we know that if we need to revise a stemless implant, it's easier than to revise a stemmed implant, and this is a study by Luis Natera from my unit. Another advantage of the stemless implants is fractures. I mean, which periprosthetic fracture would you like to treat? The one on the right or the one on the left? And unfortunately, we live on planet Earth and gravity exists. So these elderly people tend to fall. They fall, they fracture, and the fracture where the stress riser is. So the stemless implant is actually metaphysical. So you can treat them conservatively, they will heal. This lady got this function after the healing of the fracture. She's not as good as she was before the fracture, but she's functional, she's pain-free, and she's happy. The one that have displacement, then you can revise to a stemmed implant. And the vast majority of fractures we could treat conservatively like that. These good results are actually supported by the good results that the test showed as well. And the test and the Verso came out very closely at the same time in 2005. However, look at the details, because the tests actually, they have to do the the thumb test to see if the bone is good enough. And indeed, this is a paper from Philip Moroder that actually showed that they could put a stemless implant only in 18% of the cases, and the majority of the cases, they had to use the stem. And this is a case of the verso. This, you can see, he's got a complete hole there. There's an eggshell. It's complete, a huge cyst. And I used a bone graft substitute, as you can see. And actually, you can see that we created a new bone, actually, and this actually holds. If it holds in this case, it will hold in any case. So what are the limitations for stemless implant? So the limitations are actually when we don't have a proximal bone. So acute fractures, when we need a stem as a scaffold for the tuberosities, non-unions, severe bone loss that has no proximal bone at all, and the relative contraindications, which are design specific, again, as I said, soft bone, osteoporosis, and cysts, or some cases that you had a stemmed implant there and you couldn't really remove it easily with preserving the proximal bone. In that case, you have to use a stemmed implant. And for these cases, actually, you have to use a stem, like an acute fracture. You have to use a stemmed implant to have a scaffold for the tuberosities. So I'm pleased to see that in recent years, the concept that I've been preaching for the last at least 15 years has been slowly accepted, and other implants are going shorter, and more papers and meta-analysis and coming out and actually not ignoring our implant anymore. And there are other coming out, but I think that as they say, the devil or the God is in the details, and not all the stemless are the same. You have to actually look at the design features of the stemless. You have to have a good stress distribution under the implant. You have to have immediate fixation and stability within the bone. And I think one of the important features of the Verso is the large surface area to volume ratio that gives you good fixation. Because if you don't have that, as you can see with the arrow here, there's some loosening of these rounded implants, which, by the way, the test was discontinued. And there's this new prosthesis that, again, there's a paper that just came out last year, and again, it shows some loosening of this implant in the bone. Again, I'm just mentioning this paper. The patients are returning to sport, and I don't limit them to do anything, and you can see here, they can do this. There's one patient that's playing ice hockey and rowing on the river, and this gentleman that actually came with this fracture sequela, severe fracture sequela, was operated by someone else with a HEMI. I revised him to a Verso 11 years ago, and he's got good full function. And that's what he does. That's so I'm not actually suggesting that all my patients will jump out of airplanes, but that's what he does. And actually, he told me that I've improved his technique because he couldn't open his arm before. Now he can open the arm. So before he used to go down in spirals. Now he can fly. So to conclude, the stemless reverse shoulder give an excellent long-term clinical and radiologic results. It's bone preserving, easy and quicker insertion. I didn't have time to show you, but actually the set is very simple. It can be performed under block only or local anesthesia. It's good initial fixation and stability, good longevity, no stress shielding, and good load transfer under the implant. Good rotational movement for ADL, and easy revisability if needed. So it fits all the boxes that we mentioned earlier. Thank you very much.